Thank you very much. And thank you very much, everyone, for having me. And just to say, so this is really an opportunity, not just to talk about this study, but also to showcase the value of using linked electronic health records of parents and children in the early years. So I want you to keep that in mind as we go along. And the product of this, it's very much a team effort, so it's been supervised by some brilliant of my colleagues, Professor Ruth Gilbert, Becca Lacey, and Professor Jean Feather. So I'm going to kick off. 1 in 5 mothers experience intimate partner violence in England. This is over 2.2 million women. These women often feel trapped, restricted, and they fear living. And what's really important in this study is that they often fear reaching out in case they might lose their children. So IPV are behaviors with an intimate relationship that's causing any form of biopsychosocial harm. And it affects children, and it affects generations of children after them. And children exposed to IPV are therefore included as victims in their own right, which is one of the major advancements of the new, relatively new domestic abuse bill that was introduced. Families affected by IPV often face numerous mental health problems, social care issues, directly by the abuse or by other factors. But what it means that these families and parents often present to healthcare more often. For example, in England and Wales, we know that 1 in 5 of all police requested call-outs are for something related to IPV. And the problem is, it's so hidden. So despite the increased frequency of healthcare use, practitioners still don't identify it. In fact, of all the violence, IPV is probably one of the most hidden forms of all. And it remains buried deep within the family. And we know this because as part of my team, we've done an initial study where we're looking at IPV in the community. And it's a study led by David Gontek and Becca Lacey at UCL. And we examined IPV in the community, and we used the Alsbach birth court study. And for those who don't know, it's children who are born across Bristol, Bath, and Gloucestershire, and it used to be called the County of Avalon. And they got to report what kind of things they experienced as the child grew up. And we're focusing on the mums, but also some of the partners. And that's where this 1 in 5 mothers comes from, the MET criteria. So if you think about this, if we have any health professionals in the audience or anyone who sat in a GP waiting room, or if you're a mum seeing other mums, 1 in 5, that is quite a lot. So most likely you have seen someone in the past week that might be affected. This is kind of what brings us to our current study, and that's using electronic health records. And that's because the fact is there's not very much relevant clinical evidence where various signs have been studied in terms of electronic health records, or where clinicians have documented various signs that we can link to potential IPV. So there's very little relevance to healthcare at the moment. And what that also means is that there is limited clinical guidelines to guide professionals, especially in general practice and A&E, about when should we ask parents or children about IPV? What kind of signs? What's the threshold of asking? And that's really the question we're trying to answer, in addition to try to showcase what electronic health records could do. So in this study, we had two aims using recorded data of children and parents. The first one was to identify clinically relevant indicators of IPV in parents and children who present to healthcare in the first 1,000 days. And then the second one is, given that you identified IPV, what are these parents and children, parents mainly, what are their needs? What is it they need help with? So to do this, we are using linked electronic health records of mothers, fathers, and children, where they are followed from 1 year before birth up to 2 years after birth. So it's kind of covering the 1,000-day period, which aligns with government policies and support programs that are coming out. And to do this, we're using a birth cohort of about 130,000 mothers, fathers, and children. And we're using the clinical research practice database, which is called CPD Gold. So this includes families who registered across 400 GP practices across England. And just to say, not all children will have an identified dad or a potential dad. So for these mother-child pairs, we identified about 73% who had a potential dad. And I won't go into details, but it is much trickier to link a potential dad in the household than it is to link the mum. So just to bear in mind, they won't all have a dad in the household. And to really grasp the study, I've tried to lay it out here about and the relevance to healthcare professionals and people who work in public health, the value of using the linked records. So you might think about a woman who just gets notified that they are pregnant, they visit the GP, and they would do this repeatedly throughout the antenatal period. So in England, particularly, first-time mothers are eligible for up to 13 antenatal appointments. So there's quite a lot that can go on in that period. And this is rich data that's been collected for those 9 months. And then when the birth happens, that data gets linked with the mum. And then we also identify the dad in the household. And we follow that triad, so to speak, across linked data sources. So the hospital episode statistics, which include admissions. We also include the A&E and outpatient visits. And we also linked to death records because there is some data there as well. And all of this obviously gets stored in a secure database, and it's all non-identifiable data we're talking about. So we did that 1 year before birth and following them up to 2 years after birth. And to study clinical indicators, we looked at 33 different indicators of family adversities and suspicious healthcare presentations. And these are based on different domains of adverse childhood experiences, for example, parental mental health problems, substance misuse, adverse family environments, and high-risk presentations of trauma treatments or various injuries or signs that might ping the doctor that something's going on there. And in this study, the outcome is IPV, so intimate partner violence. But normally IPV is actually part of the adverse childhood experiences. But in this case, we've separated from the actual exposure. And it's IPV in the parents and or the child. So I'll get to that very soon. But we are using a think family approach. And this means that either record that indicates, if we take IPV, for example, if there is a description in the child that indicates there might be IPV, that would be counted. Or vice versa, if it's one in the mum, but not in the child or in the dad, and so on. So we're using very much of a think family approach. We're drawing from all the data sources available. And if you think about this in reality, if you would do this in practice, this is an extremely complex task to calculate risk from. Because even me, if I would try to formulate psychologists different mechanisms from different people, that would become very complex very quickly. But with a computer, we're able to do these a little bit more in a simpler way. So I won't go into details, but we calculated the prevalence using inverse probability weights to account for some loss to follow-up and people who didn't register within the time period. And what we found within this cohort was that 2.1% had recorded IPV. So it was heavily under-recorded. However, we found that 41% had any family adversity. So any of these domains that come up. So the prevalence obviously range, so 27% parental mental health problems, 14% substance misuse, 12 for adverse family environments, 6% for high-risk presentation. So this was what was recorded in the general population of those who visit the GP in this cohort. Now, if we try to translate that to the actual question and risk, I want to show you that I want to draw your attention to the link between family adverse and IPV. And what we could see was that IPV was heavily clustered among all the other adversities. So it's not in isolation, but it's hidden beneath. It's just not what's coming out. And that's what this Venn diagram shows you. So if you take all individuals with any recorded adversity, including IPV, how much of the other adversities do they have? Well, the biggest blurb here is the parental mental health problems. So overall, it shows you that over 80% of families with IPV had at least one other form of adverse presentation. And so what that means is that it meant that actually having any of these adversity indicators meant that it significantly increased the probability that there was IPV in the family. So if a family had no adversity, the risk was 1 in 175 parents and children. But with any adversity, that risk went up to 1 in 22. So now I'll list all the other risk estimates that were linked to the different domains here. But what I want to draw your attention to is the different family members. So this triad here to the left. And when we look at the family members of this triad, so the child, the mom, and the dad, if one parent had any ACEs or adversity, then the risk was 1 in 29. So if only one parent had. But the risk increased significantly for each person where there was an adversity indicator recorded. So if you identified one parent and a child, all of a sudden it was 1 in 11. And as you can see, it goes up. And it's just to really highlight the importance of a think family approach, that we're drawing all those pieces together when we think about unpicking what's going on underneath the surface. Now, the last part, so given that we have identified IPV, we were interested in their actual healthcare presentations. And the main thing I would say here is that there was a very elevated prevalence of mental health problems, which you can, which you probably have already taken home from the previous slides. But another thing was the physical health problem was also significantly elevated. Chronic pain was a particular prevalent domain. So you have, let me see if I can pull out some the numbers here. I think it was almost double prevalence. But overall, all of the different physical health issues among the mothers were elevated, significantly more elevated. Among the dads, there was some that were similar, and some, for example, chronic pain that was significantly higher. So now that's it. So if we go back to the original question and aims of this study, I hope that I'm really trying to hone in the message that this study was trying to answer the question of when is it appropriate to ask about IPV in parents and children. And we're hoping the findings will help inform some of the NICE guidelines and NIHR guidelines, which currently don't have the specifics about this when it comes to general practice and A&E. And obviously, we can't just be asking people, we need to do it in a sensitive way and a safe way. So, because it affects the masses of the population, so general practitioners and A&E, people need training in recognizing and responding to IPV. And another thing I hope I've highlighted is the think family approach and how you can use data linkage, electronic health records to do that. This was mentioned in the beginning. The study has been published. Please have a look if you want to know anything more. And we also have a website where we publish all these indicators as freely available with published guidance on how to incorporate into your data. Finally, acknowledgement, the study was funded by the NIHR and is part of the Children and Families Policy Research Unit. We're also very fortunate to have a collaborating Caliber who has helped us with the resource because they held the license. That was it for me. Thank you.